Welcome to Pediatric. I'm Zach Hodges, a pediatric intensivist from the University of Texas Southwestern in Dallas.
And I'm Alice Shanklin, a pediatric intensivist at Cohen Children's Medical Center in New York. We're here to talk about NAVA with Dr. Guillaume Emeriaud. Dr. Emeriaud, can you introduce yourself and tell us where you work and your academic affiliations?
Yes, nice to meet you. Thanks for inviting me. I'm Guillaume Emeriaud. I'm a professor of pediatrics at the University of Montreal and working at Sainte Justine Hospital. I'm also a physician scientist, particularly interested in mechanical ventilation and how to improve patient-ventilator interactions.
Please tell us more about your professional journey thus far. Obviously, you have an MD PhD. And how did you learn more about your interest of studying mechanical ventilation?
Well, in fact, as you may hear, I come from France, so I did my medical degree in France, also my pediatrics degree in France, and I came to Montreal for the training in pediatric critical care as a fellow at Sainte Justine Hospital. And this is where I started my research journey and in mechanical ventilation. Why mechanical ventilation? Probably the fact that I come from France, because in France and in Europe in general, there are no respiratory therapists in the PQ.
Wow.
And so it's very different. And so the medical team is much more involved in the management of the ventilation. And so that's why probably mechanical ventilation is a domain of interest for many European scientists, I think.
Wow, I didn't know that. Did you set up the circuits and everything?
Yeah.
Wow.
Yeah. So you have to bring the bottle of nitric oxide, etc., and connect everything, etc.
Wow, that's so interesting. So you come to Canada, you have this strong interest in mechanical ventilation. How did you become interested in NAVA, and what have you sort of done related to this topic?
Yeah, so for NAVA, it has been also a long journey because in fact, as a fellow, my research project was on the EEDI monitoring, and it was now more than 25 years ago, or about 25 years ago. And so you can imagine all the progress that have been made over these years. But at this time, it was only working on how to collect the information, the diaphragmatic electrical activity signal. And basically, it was relatively the same principle as what is used and now what is commercialized. But at this point, it was almost homemade, in fact. And we collected the signals and we were able to look at the interactions between the patient and the ventilator activity and synchronization. At this point, it was not connected to a ventilator. It was connected to a computer. But so we started with basic work on EDI monitoring. And then progressively, I've seen across my career, which is fantastic. In fact, the evolution of the technology. I did not invent NAVA myself. Of course, I work on that and I accompanied the development, but I was able to see the progression and that the technology reached the clinical bedside. It's quite uncommon. It's not that frequent. And so it's great for clinical scientists, to see our research come to the bedside. As we have the experience from the preliminary papers, the preliminary work on what is diaphragmatic electrical activity, etc., of course, it's much easier than to progressively incorporate the idea of the theory of NAVA. And this has helped a lot. And I think that's one of the reasons why NAVA is primarily used a lot in teams that have been involved from the beginning. And it's a bit difficult to reach teams that are not used to that. And so this is one of the specificities of NAVA.
No, I really appreciate your career up to this point that has been so invested to NAVA and mechanical ventilation. It's clear that you're the right expert for today's episode. As we move to the last part of our intro, any conflicts of interest to disclose, and at the same time, we'd ask that you please resolve a controversy for us. Our ARDS guidelines in pediatric critical care, is it PALIC or is it PALIC?
So I will start for the conflict of interest because that's something that's very important because I talk a lot about NAVA, but I want to make it very clear that I have no direct commercial relationship with Maquet and no real conflict of interest. I want to disclose that Maquet has supported one preliminary study on prototype that is not really directed to NAVA, NeuroPAP, which is a form of continuous NAVA, in fact. So I led this study and it was financially supported by Maquet. But beyond that, I do not have any connections with Maquet. So it's important. And to be honest, for the question about panic,
as a co-author of the document,
the executive summary.
I will defer that question, and I prefer that an English-speaking people can answer that, but I will say panic. Yeah.
Okay.
He's taking a side, guys.
He's commented.
All right, let's talk about the clinical applications. Alice, you want to bring us our case?
Absolutely. So we've got a 4-month-old infant who's an ex-28-weeker admitted to the PICU with respiratory failure due to infection with RSV. She was initially supported with high-flow nasal cannula in the emergency department, but has ongoing tachypnea and moderate severe workup breathing, now on CPAP. The team is considering increasing to a bi-level non-invasive support, possibly NAVA. So before we get into this case, what is NAVA? What exactly are you doing here, and how does it work?
Yes, that's the great example, because I think that's one of the best indication for NAVA, and we can discuss that later. So what is NAVA? In fact, the idea is that it's a mode that will respond to the patient demand at any time, and in time for the synchronization and in amplitude for the support. So how does it work? In fact, it's based on the fact that we monitor the diaphragmatic electrical activity, as I mentioned before, with a nasogastric tube, which is a relatively classic nasogastric tube, which can be used for feeding or suctioning, which also is equipped with microelectrodes. And that microelectrodes capture continuously the electrical activation of the diaphragm. At the bottom of the screen of the ventilator, you will see, in addition to the usual curves like pressure or flow time curve, you will have the EADI curve, the diaphragmatic electrical activity, which reflects all the patient inspiration that comes over time. So the ventilator will be triggered by this signal. And so as soon as the diaphragmatic electrical activity rises, that will start pressure support. And when the wave decreases, it's the end of inspiration, and the ventilator will go to the PEEP level. So it's a synchronization of the pressure support. And the second specificity is that the magnitude of the support is proportional to the EADI curve. So if the patient takes a deep breath with a large magnitude, then the patient will receive more support because the pressure support will be proportional. Of course, there is a maximum. It's usually limited to a maximal pressure that you can set. And usually, for example, in non-invasive ventilation, you will limit that to 20 centimeters of water, for example, and then you get a ventilation that is synchronized and proportional to the patient drive.
Oh, excellent.
And for someone who perhaps has never worked with NAVA before, it seems like the real advantage is you have this nasogastric tube with electrical probes that are in the esophagus adjacent to the diaphragm. And you're able to measure how hard essentially the patient's working to breathe in those electrical impulses coming from the diaphragm. And that does two things. It allows the ventilator to be more appropriately synchronized with the patient and really closely monitor like how much that child is working to breathe and respond to that by giving more support. Is that summarize it okay?
Exactly. That's a very good point. In fact, it's a new tool that you have at the bedside. How much the patient is actively participating in his respiration, which in non-invasive ventilation, it's not so surprising. You have a relatively good activity, a good drive, and that's what you see clinically, But in intubated patients, you have the same information. And when you start using that in intubated patients, you realize that a lot of patients have very low or even no spontaneous activity. Even when you think that they are actively breathing or triggering the ventilator, their spontaneous activity is in fact very small. And so this is an interesting and helpful monitoring tool, the diaphragmatic electrical activity at the bedside. Sometimes we even use it only for that. In fact, you can have the monitoring without the connection to NAVA. You have the connection to the ventilator, but you are not obliged to use it for the ventilation. So it can be an additional monitoring on your ventilator.
Oh, wow. And so the EADI, it sounds like it gives you a nice curve for inspiration, expiration. Is this something that gets put up on the monitor? Can you walk into the room and see it?
Exactly. It's an additional curve. So you are on the ventilator screen, you have the pressure, time curve, the flow time curve, the volume time curve, and at the bottom, you have the EADI. So you see all the inspiratory wave by the patients. So it's only the inspiration phase. In fact, I've worked a lot also on the activity during the expiration, which is a mechanism that may be involved by the patient as a braking action of the diaphragm. The diaphragm is an inspiratory muscle. So if it stays activated during the expiration, that means that the patients try to keep some air at some points, but it may be beyond discussion. I think it's not really directly related to NAVA, but that's also, as you mentioned, the inspiratory and expiratory phase. But at the expiration phase, usually you have almost no activity, in fact, but you may keep some tonic activity that is called. One important concept for people that are not directly aware of EADI is that it's an electrical signal. So this means that it's a reflection of the respiratory center output that comes from the phrenic nerve, and then it's relatively well correlated in time and in amplitude with the output of the phrenic nerve. The advantage is that it's fast as it's an electrical signal. So it's very fast from the brain, very close to the brain in time. It's not a mechanical information. So you can have a weak diaphragm and strong diaphragm activity because the patient will want to get more force, so he will have large activity. But if the diaphragm is weak, you have a small effort if you measure the effort. So it's important to make the distinction. It's an activation, an electrical activation. It reflects what the patient wants, like his drive, but not really the force of the diaphragm.
So like one immediate application of that, if your patient had perhaps a phrenic nerve injury from a prior surgery, et cetera, this would perhaps not be a wonderful tool for that patient, right?
In fact, we are looking at that. We use it regularly in unilateral diaphragm palsy because on the contrary, well, in fact, these patients, as long as you have one of the sides that is working, you will get the signal. And in fact, these patients usually don't really tolerate the fact that they are asynchronous. So if you can have the information and just give the support when they have the inspiration, it works really well. But if you have a bilateral palsy, then of course that won't work.
Wonderful. For someone who's listening in who perhaps hasn't seen NAVA being used in their unit, there might be a concern about what a large amount of special equipment required to deliver this therapy. Of course, it sounds like the esophageal probes is a necessity. Is there any other specialized equipment?
Yeah, in fact, that's one of the issues is that it's commercialized only in one ventilator. So this is the Marquet ventilator, the Servo I, Servo U, Servo N that are capable to do that NAVA. I don't know how it will last like that. Fully at some point there will be other ventilator that do that, but for now it's the case. And in this ventilator, you also have to have a module for NAVA, so because you can have these ventilators without the module. So it's a small part in the ventilator that makes it possible to connect the EDI signal. And then, of course, the catheters.
So if you need servo use, but you need to sort of buy them with the...
Yeah, the option. Yeah.
The option. Okay.
And I know cost in healthcare can be somewhat nebulous, but is it generally thought that these esophageal probes are very expensive and cost prohibitive for units?
Yeah, that's very frequent limitations for people that mention that I discussed. And it's at least a few years ago, it was $200 per catheter. So it's not cheap. And so this is something we are considering. In fact, we are not using NAVA in all patients. But at some point, it's not also like a monoclonal antibody, Yes. And if you compare for the duration of ventilation and what it costs, if you can imagine that in some case you will have a benefit, probably that compensate. But of course, that is not demonstrated for now, in fact.
Oh, I have to know while we're talking about the probe, is it tough to get it in the right spot?
In fact, it's relatively simple. Now there's a clinical equation that we use to insert the catheter. So you measure the physical distance before inserting the catheter. So distance from the ear, nose, and xiphoid. And then this is the NEX distance. And there's an equation, depending on the type of the catheter, you multiply by a factor, etc. And that gives you the estimated position of the catheter. You put the catheter, and then you have a window on the ventilator that indicates the position of the catheter. And this is something the team has to learn because Sometimes people pay a lot of attention of the waveform, but first, it's one very important thing is that to make it clear that the EKG waveforms are at the correct position before going to the additional diaphragmatic activity that appears in color. People pay a lot of attention at the color, but in my experience, the EKG positioning is more important. So you start with the equation, then you look at the EKG signal, and then you can verify the positioning of the color curves that display the diaphragm activity. Interestingly, you have the EKG. So you have the P wave, the QRS. So if you have a patient and you're not sure if the patient is in a sinusal rhythm, you can see that.
Oh, nice. So function correctly as a cardiac lead first, and then, okay, how does the diaphragm look?
And is there a radio opaque signal on these tubes that will indicate where is that related to the diaphragm?
So you don't really see the electrodes. To be honest, I haven't paid so much attention, but you see the NG tube. And importantly, sometimes the NG tube may seem to be a bit too far in the stomach. And so sometimes there's the temptation to remove it a bit, especially in very small kids. But then you have to remember that you don't want to lose the electrical signal. So very rarely you may have a conflict about the correct positioning and the electrical activity, but usually the electrical activity is also the correct positioning.
Oh, nice.
So we've talked quite a bit about the physiologic rationale and some of the advantages. Is there any other advantages of NAVA that you'd like to highlight compared to conventional non-invasive or even invasive mechanical ventilation?
Well, for non-invasive ventilation, the major advantage is the synchronization, and especially in infants, like the one you described, small infants with sick lungs, etc. It's very difficult for a classical ventilator to correctly identify the patient effort and respond in time. And it's very clear that NAVA improves synchronization for that. For the proportional ventilation theory, in non-invasive ventilation, to be honest, I'm not sure this makes such a huge difference. But in the invasive condition, this makes a difference. In fact, as I mentioned, in conventional ventilation, in invasive ventilation, frequently you over-assist the patient. So you provide sufficient support that the patient don't really need to breathe, especially with the sedation that decrease a bit the drive. And so the patient has no activity. So you can measure that. And if you switch to NAVA and the patient is able to be ventilated with NAVA, then you maintain the diaphragm activity. The patient has to breathe. And so it's very important to avoid over-assistance and also to avoid under-assistance. Because if the patient does not receive sufficient support, it will increase his drive, he will receive more support. It's very a mode that responds to the demand. If you compare to volume control ventilation, if the patient has an increased drive, he will receive less support because the ventilator will just decrease the pressure. So this is a different concept of what you want to do. The concept here is you want to unload the respiratory work. So if the patient has a high drive, he will receive more support, he will decrease his drive. If the patient is too supported, then the EDI will be low. And so the ventilator will decrease the assist as it's proportional. And you will see reappear the patient participation. And so I think, coming back to your question about the theoretical advantage or rationale for the NAVA, I think it's very close to a concept that is emerging over the last few years, that the ventilation should be lung protective, but also diaphragm protective. And maintaining an activity of the diaphragm sufficient, but not excessive, because you don't want the diaphragm to be too exhausted on the other side. So maintaining the right level of activity could be one of the objectives. And usually it's one of the concepts with NAVA. It's that you want that safe window at some point.
Oh, good. It's easy to think that NAVA is all about just the timing of the breaths and kind of picturing yourself with the pressure support, and the pressure support starts based on the correct time because of the electrical activity. And important to clarify that it's also sort of a direct proportion or equation that's giving you the support. To that end, let's get into some terms that are important to really understand as we talk about this mode. We could pretend that Zach is signing out my first NAVA patient to me and I have questions. Okay, so EDI, are there numbers that we should be aware of that we're really looking at, or is it all about the curve?
Yeah, in fact, we're measuring EDI and you're measuring all the other variables that you usually monitor during conventional ventilation. The other features that you should be aware of are the settings for NAVA. And in fact, it's quite simple, which does not mean that it's simple to set them, but it's simple because there are not a lot of settings. There's only the FiO2, of course, the PEEP level, which is the same PEEP level rationale as in conventional ventilation. And you have the NAVA level. You don't have a respiratory rate or the level of volume or the level of pressure, except that you will set up backup ventilation, of course. So it's important. But usually the most important setting to set is the NAVA level. And the NAVA level, you should see that as a gain factor. It's the factor that will convert your diaphragmatic electrical activity into a pressure assist. And so for a very simple example, if your NAVA level is 0.5 and your diaphragmatic electrical activity increased to 10, then the level of pressure will be 10 multiplied by 0.5. So 5 centimeters of water in addition to the PEEP. So that's the role of the NAVA level, is that it converts the diaphragmatic electrical signal into a pressure support. And of course, as I mentioned, if the patient wants to take a deep breath, and the example that you provided probably has a very high level of EDI, and you don't want the patient to receive 100 centimeters of water, so you will have a maximal pressure that you can set. Strangely, this is not exactly the maximal pressure that you are setting, but the alarm. So if you set the alarm at 25, for example, this will blunt the pressure at 20. So 5 centimeters below the alarm. And that's what we would use probably in these patients. In non-invasive ventilation, usually we don't really want more than 20. So we set the maximal pressure at 25.
Oh, nice. Can you give me an example of the range of NAVA levels? What's low, medium, and high support for non-invasive and then for invasive?
Yeah, usually in NIV, it's below 1 is a usual window. It's between 0.5 and 1, probably. And invasive ventilation, frequently the patient have received more support and they have lower drive. And so it's around 1, 1.5, 2. It's rare that we go above 1.5, to be honest, in our unit, but some units use more than that. But usually for us, it's between 1 and 1.5. And during the weaning, we go down to 0.5 and sometimes very low level when we want to wean slowly.
So it seems clear that titrating the NAVA level up and down, essentially how you increase support or take away support for the patient.
Exact. In fact, you try to adapt the support, but the patient is automatically responding to that. So if the patient receives too much support, it will decrease his activity. So while the change in a NAVA level don't always correlate with a change in the delivered ventilation. That's important. But there are two situations. When you have a patient with a low drive, I would say probably in invasive ventilation, and you want to increase the ventilation, there are two possibilities. In fact, either the patient is awake and is just too supported. So then in that case, if he's over supported and you still increase the NAVA level, you will just decrease more his drive. And so the patient will not want what you are giving. You will not be able to increase the support because there's no reason, because the patient don't really want it. But at some point, you have to be aware also that the patient also can be too sedated. And that's what we see, for example, in post-operative patients. They have weak activity, but it's not because they are over-supported. It's because they are over-sedated. And then in these patients, it's important not to decrease too much the NAVA level, because that was sometimes the reaction I saw, that, the patient has no activity, let's decrease the NAVA level because we want him to breathe deeper. But if he's not able to increase his drive, then you decrease the ventilation. So sometimes you just have to be aware that this patient has 2, 3, 5 microvolts. It's quite low, but it's his maximum. And then let's keep the NAVA level quite high because you want him to be supported with this low level.
You've referenced a couple of times that we're constantly measuring electrical activity of the diaphragm. And it seems like that there is this optimal range, generally speaking, for all patients, but there might be a more nuance where each patient has their own optimal range based on a number of clinical factors. Will you tell us more about that?
Yeah. That's where gaining more experience at some point help a lot. If we want to keep the problem simple, and you can see that there are several very good papers that explain how to use NAVA, in fact, in simple way. And they just usually take the classical window of 5 to 20 microvolt, for example. And we consider that the correct or the almost normal diaphragmatic electrical activity is above 5 and below 20. And so you will titrate the NAVA level to be maintained in this range. One side note at this point is that it's important because sometimes in teams that start using NAVA, they adapt the NAVA level every 10 minutes or every hours, etc. It's not really what we are doing. In fact, the patient will fluctuate, but you don't want to adjust all the time. The patient will adjust by himself all the time. So usually we change it when it's needed because the patient is in difficulty or his condition has changed, but maybe 2, 3, 4 times a day, but not that much. In fact, we don't try to follow all the change of the patient. I come back to my usual target of 5 to 20 microvolts, which works quite well in invasive ventilation. But in fact, you have just to be aware that some patients will have high activity. And I mentioned at the beginning, a patient with a weak diaphragm, like a patient with a neuromuscular disease, for example, or a patient that has stayed for a very long time on ventilation, or a patient that have a very sick lung disease. Of course, we'll try to compensate that by a strong activity. And if you try to maintain this type of patient at below 20 microvolt, then probably you will over-support them and you will never be able to win them. So at some point, it's important to see where you are and where your patient should be and where you want to be the next day and the next week. In fact, it's depending on the type of patients, and to try to bring the patients these targets, in fact. There's some individualization, but I would say that in most patients, and especially in an invasive ventilation, the patient has their own drive, which is quite high. And usually the pressure will be limited by the maximal pressure, and the NAVA level will not make such a huge difference. And that's why I think this is a good population to start when you are not used to use NAVA, because there's no major error yet that you can do. It's not a problem if you set 0.6 when it should be 0.8. It will not change that much the results in non-invasive ventilation.
That's fascinating. So it seems like some take-home points are, as the electrical activity of the diaphragm, as the number increases and perhaps goes above 20, that's telling you that this child is being very active in their work or breathing, perhaps their electrical impulse to try to help them breathe more. And that might be adaptive because they have worsening lung disease. That might suggest they need more support, or it might not. And it seems the trajectory is much more important as you step back over 24 to 48 hours, more so than it is what is happening in this individual moment for helping you decide whether to titrate therapy or not. Does that sound right?
Yeah, very well summarized. And in your example, because the other direction is very helpful too. So if in your example, if the patient has, let's say, 60 or 40 microvolt, very high level of effort that I would expect in this type of patient, you start something, probably you start NAVA, but what you expect is that in a few hours, the drive will decrease because you don't expect this patient to have such high activity. And this you correlate with your clinical exam. You see that the patient has a high respiratory effort, and probably this will go together. In fact, the patient will have less effort and you will see a nice decrease in diaphragmatic electrical activity if what you're doing is successful. If the patient is not improving, that's a concern, in fact, because you see the diaphragm activity which remains very high. That means the patient will continue to receive a high support and at the same time is doing a lot of efforts. So if you make the addition between the positive pressure and the negative the pressure that the patient is doing, that set the place maybe for the potential patient self-inflicted lung injury. At least this concept may occur in this situation. That's something that has to be kept in mind. It's not a problem for a patient to have high activity at some point and to start NAVA, but you have to be aware that it will receive more support at this point. And the expectation is that it will unload the patient. And so the patient should improve and the drive should decrease after.
It's a really great reminder. So it's not a knee-jerk reaction of increased electrical activity of the diaphragm must increase NAVA level. The answer might be sedation. It might be, should we consider intubating this patient?
At some point, if he's not responding to the addition of support and you don't see this improvement, you may go to the next step indeed. Or to combine with sedation. In our unit, we use a lot dexmedetomidine in this type of patient, and probably this is for the comfort to maintain the mask, NIV, etc. But it's also play a role in decreasing the drive.
All right, so we've really leaned in here and we talked about how things might not be as simple as we maybe perhaps once thought, where EDI and NAVA level titration is not just with one is elevated, you adjust the other. Do you see any other disadvantages that you'd like the listeners to know about with NAVA?
Well, in fact, I think the most important one is the one that I just mentioned, with the risk of providing excessive support when the drive is not decreasing, and then you have the combination of two could be a risk for patient self-inflicted lung injury. To be honest, it's not frequent and it's a minority of cases, but it's possible. But one of the other disadvantages, clear, which is a bit linked to the same concept, is that the prolongation of NIV that is not working. If the patient is failing, we use NAVA a lot. And at some point, if the patient is not responding, you have to intubate and make sure you don't intubate too late. So it's a very difficult question, but it's the same question as in conventional NIV. And finally, I'm not sure it's a disadvantage, but it's a discomfort for the clinical team, is that you just provide all the control to the patient. And it's probably an advantage, in my opinion, but it's difficult for the team because especially in invasive ventilation, you see the patient take 4 ml per kilo at 70 per minute, and you're not used to see that, but the patient is comfortable, is okay, and sometimes we don't want that. And sometimes the patient is awake and will take 10 ml per kilos and it will decrease. And so it's a bit difficult sometimes to be sure that the patient is right. It's quite rare in physiology that the patient is not doing the best thing, but it may occur sometime. And it's the same as for intubation in the condition. The question arises in patients with a hypoxemic respiratory failure. It takes a large effort. At some points, you'd better just sedate them and paralyze them. But to be honest, it's the same in any mode. In fact, in volume control, you could have the same pattern. If the patient wants to take 10 ml per kilo and you don't block them, they will get them, whatever the mode. But NAVA will facilitate that.
So if anyone spends a little time in critical care, they'll see, gosh, there could be dozens of ways that we could ventilate these patients. And if you do a little perusing literature, you'll see how difficult it is to link the methods and the modes that we choose on the ventilator to directly affect patient outcomes. What evidence do we have supporting NAVA for our critically ill kids?
We don't have a very strong level of evidence, to be honest. There are multiple physiological studies that have confirmed the fact that it's improving synchronization. So that's not a question, I think, in both adults, pediatrics, invasive, non-invasive condition. This is not an issue. There are some good physiological studies that show also that it's associated with improved comfort or reduced level of pressure, maybe slight improvement in oxygenation, but not very strong evidence. There has been one randomized control study, which is not very well known, from a Finland team, Merja Kallio, and she published a randomized control trial at the beginning of NAVA, probably 10 years ago. It's 170 patients or something. And she randomized any patient in the PQ, and it was in invasive ventilation condition. And so it was very difficult to show a difference because these are a lot of patients who were just extubated after 12 hours. There were post-op patients, etc. And so the RCT was negative as for the primary outcome, that was the rapidity to win the patients. But it was very close, in fact, to significance. In fact, it was like maybe a p-value of 0.07 or whatever. There were some positive signals, but not a positive trial. She observes also lower level of support, so ventilation that is less aggressive, less sedation, but again, not a strong indication of a positive primary outcome. So I think that's the major limitation for now, in fact, and we see in our practice that it works, to be honest, but we see that it's not translated everywhere. And so we are working on the next step, which is we have to do a larger CT. And so I think that's something that is missing currently. But in fact, when you're managing a patient in a PICU, there are multiple things that are not supported by strong evidence. And especially for ventilation, in fact, there's no study that shows you that it's best to use BiPAP versus CPAP in bronchiolitis. And I think when you're managing a bronchiolitis, there are more evidence to support NAVA versus BiPAP because at least you know that it's synchronized. So when you have no strong evidence, you go to the physiology, and that's where it's very important to know how a ventilator works, what's the physiology of mechanical ventilation, and then to make your mind. And at some point, if you know that the mode is able to synchronize the patient, probably it will help the patient. Can it be also deleterious by other ways? It's possible. Is it costly? It's possible. So we have to do future study. But when you're managing a patient, we have to rely on physiology at some point.
Yeah, that's an incredible physiologic, directed, but experience-led response to that question. There's so many things that we do and then we feel really confidently about that we don't have wonderful evidence for. As we have developed this pattern and experience, we used this mode last time and it supported the patient well, we get a little skeptical when we think about incorporating new variables into our clinical practice. This has been an incredible primer on NAVA. And I think as we look to close part one of the conversation, my last question for you would be, if someone is thinking about incorporating more NAVA into their practice, what is the low-hanging fruit here? What is the patient population they should think about doing first? And then as you close that, what populations do you like to treat patients with NAVA in your clinical practice?
The low-hanging fruit is clearly the NIV in infants. That's where the problem is terribly synchronized. Even if you look closely, you may think they are synchronized, but if you get the signal and you compare the diaphragm activity and the actual pressure there, it's very difficult to synchronize this patient. So I think starting with a non-invasive patient is simpler and it makes an important difference. And it allows the people to get used to EDI monitoring and to see how it works, etc. So I think it's probably the best way to start. Other population in invasive ventilation that benefits are the patients that are difficult to ventilate. The problem is that, so it may be because they don't tolerate asynchrony or because they are very sick. And the problem is that this population is difficult to manage with in NAVA, invasive NAVA, because they have a very high drive sometimes. But it's the population we think will benefit the most, but it's also the population which is difficult to ventilate, like the severe BPD patients, severe tracheomalacia, etc. All these patients in our unit finally end up on NAVA at some point, but they are not simple to manage, to be honest. And there may be some risk in these patients for overinflation. So it's not easy. Another population of our interest is cardiac patients. And we use it a lot in those patients because two different aspects. One aspect is the patient in whom we want to decrease the pressure, which is very important for all, right side failure or passive flow physiology in the lungs, like a patient with Fallot, Fontan, Glenn, or whatever. You prefer them to be extubated, but if they are intubated, being on NAVA usually allows more patient participation, lower pressure, and so a benefit on the hemodynamic, probably. We are working on that on a study, but it's quite obvious. And even our cardiac surgeon like NAVA for that. It's rare that you have interaction and ventilation with the surgeons, but they have understood that. And the other part for the cardiac patients are the opposite. In fact, the ones that benefit from positive pressure, like the patient with left side failure, like myocarditis or even a hypoplastic left heart, a patient complex or a patient in cardiac failure. When you want to wean them, you want to be sure before you extubate them that they tolerate to be weaned. And doing a transition to NAVA is a good step, in fact. You decrease the ventilation, you let the patient breathe, you see if the patient tolerates. If the patient does not tolerate going to NAVA, then probably that's not a good candidate for an extubation. And so that's a winning strategy for us in this patient. So that's the populations where we see a lot of difference. And also the neurological patients, like I would say in general, but it's a smaller niche, but also there could be an interesting patient where you would see a benefit, at least for the monitoring part for the neurological patients.
Oh, wow. Well, that's exciting. And we might not have the RCT, but it sounds so good that the cardiac surgeons are asking for it by name.